Thank you very much. There we go. The recording has started, yeah? Okay.
Yes, you can go ahead.
Good morning, everyone, and welcome to this second DisQo webinar. My name is Raymond Gemen. I'm a Senior Policy Manager for Health Equity at EPHA, the European Public Health Alliance. I'm greeting you today on behalf of DisQo, a network of about 40 organizations working across sectors that recognize racism and discrimination as fundamental determinants of health, and who want to join forces to take an anti-racist and anti-discrimination stance against the issue. We operate across sectors, but with a focus on health. And we believe that within the health domain, this issue has been and is insufficiently recognized and addressed so far. To that end, we are currently developing a joint statement summarizing our common position with key priorities and actions that we have identified should be taken to address the issue. This joint statement will be presented on the 19th of April at the Health Policy Platform annual meeting in Luxembourg. And if you're interested to contribute and or endorse this joint statement as an organization, that's important, please do reach out to me. As I said, this is the second webinar of a series of 3. In January, we discussed the importance of language and definitions to create greater understanding in terms of the level of understanding of the issue, but also of the actual definitions. What is, for example, structural racism, and how does it differ from institutional racism, for example? Or what's the difference between health equities or health inequalities and health inequities? These are all important to create safe spaces for dialogue, and safe spaces in which it's okay to make mistakes as long as the intentions are sincere. And a link to this first webinar is in today's agenda. Then on Thursday next week, we'll have our third and for the time being last webinar on the topic. And we will be discussing breaking silos and taking action, which kind of brings all of the work of the DisQo network this far together. And from the anti-racism and diversity event in the EU Parliament this week, on Tuesday, on the International Day for the Elimination of Racial Discrimination, it was clear that a lot of silo breaking is still to be done. Health, for example, while implicitly it was present throughout the day, think, for example, of the impact of racism and discrimination on mental health or on access to healthcare services. It was hardly mentioned explicitly, so a lot of work to be done. Among other speakers, again, for next week's webinar, we have Michaela Moa, who is the first anti-racism coordinator at the European Commission, DG Justice, but that is next week. So today, we'll take a deep dive into equality data. In the UK, Black African males had a 3.7 times higher COVID-19 mortality rate than British white males during the first wave of the pandemic. If we then compare that with the EU, well, we can't, because we don't have these data. And that is exactly why today's topic is so important. No data, no problem. But to be fair, when I started to look into the topic myself a bit more as a non-expert, I realized that what might seem not that complicated from the outside is actually not that straightforward from the inside either. Take, for example, the difference between perceived or assumed versus self-identified racial or ethnic identity, or how to systematically capture personal experience of discrimination, which is a very important indicator, or how to build trust, for example, in a healthcare setting, so that patients actually have the trust and they want to hand over their data because they know it's important and they know that their data is safe and treated confidentially with care. Okay, I'm going to stop it here and give the word to the actual experts on the topic. So on the slides, you can see all of the speakers that we have for you today. Quite an attractive program, if I can say so myself. I will introduce the speakers as we go. They will cover the topic from different angles, including the EU, regional, and also a local level. What's important, if you have questions, please do drop them already in the Q&A. Jacqueline, who I will introduce to you later, she will already keep an eye on the Q&A. If you have a question for a specific speaker, please do mention the name of that speaker. And then, without further ado, I would like to introduce to you our first speaker, Daris. Daris Lewis, he's a legal and policy officer at EQUINET, the European network of equality bodies. Daris has a background in law and human rights and works on equality and non-discrimination topics, including equality data, racial discrimination and social justice. And he's also actively engaged in the core group of the DisQo network, and he will be setting the scene for today's webinar. Daris, please, over to you.
Hello, thank you, Raymond, for the introduction. I will go straight to setting the scene. I first wanted to say that to start with a story. Like a couple of years ago, I attended to a conference organized by the Portugal presidency of the EU Council, and there was this Professor Maria Casanova highlighting the fundamental value of education, and she referred to it as a portable wealth. Not only because it is intangible, but also because knowledge is power. And Michael Jones says that knowledge is powerful if it predicts, if it explains, if it enables you to envisage alternatives, but also if it gives you the knowledge that we will not otherwise have access to, and if it is obviously systematic and specialized. And in our current knowledge-based society, data lies at the heart of this knowledge. So you can this illustrates the importance that the equality data must have in the European Union. But what are we talking about when we refer to equality data collection? Well, equality data can be collected by different means: surveys, census, administrative processes, complaints data, and other sources. And within these sources, any piece of information or set of values, whether qualitative or quantitative, that is useful also for describing and analyzing the state of equality, can be referred as equality data. And moreover, personal information is connected to certain characteristics, such as race or ethnic origin, or data, for example, concerning to health, is considered or are considered as sensitive data, and that's therefore is more severely protected, not requiring data subjects informed consent. And this is one of the reasons why in general inequalities based on race, on racial and ethnic origin can only be assessed with reference to proxies, normally citizenship or migration, categories that do not require consent, but do not represent ethnicity per se, given the modern European multicultural societies. And well, race and ethnicity, just to quickly, briefly introduce our social constructs that might be actually distant or may overlap with how people identify themselves, and that are broadly defined as based on a shared understanding of history, territorial origins of a community, as well as cultural characteristics, and for example, in the case of ethnicity. But just for the case of have a better understanding on us today, when I speak about race, I speak as a cause of discrimination, and also as a generic statistical category that allows for disaggregation of any data, and that is also a personal characteristic. And now that we have a common understanding of the key topics we will be discussing today, I think that you might be wondering why does equality data not requires our attention, and it's because equality data actually have or serve for a wide range of purposes, that can be like from providing essential information to evaluate and monitor the realization of fundamental rights across equality grounds, but also it's useful for establishing whether discrimination takes place at judicial proceedings. It can also provide visibility to the nature and extent of discrimination, it constitutes the evidence also that researchers, for example, need not to take to kind of increase our understanding of discrimination, but also it shed light on the current situation of equal access to different areas across life, including health, and also what I want what I want also to go over a bit is the legal and policy framework, because there is not really a singular legislation explicitly regulating equality data. Is mainly regulated by a combination of anti-discrimination and data protection legislation. For example, and the Racial Equality Directive requires member states not to have equality bodies for the promotion of equal treatment, and the competence which must include one of them is conducting no independent surveys concerning discrimination. We are lucky to have a representative from Equality Body today that will give us more information about it, and there's no much guidance from the legal and policy framework. But what about ethnic data collection? Though actually there's no member state imposing an absolute prohibition of ethnic data collection. That's clear. And mainly is any equality data collection is done or take place according to the GDPR. Which Article 8 prohibits the processing of personal data in relation to certain special categories. This will include ethnic origin, but there are, however, exceptions. And one is that if we gather such data with consent, with the subject consent, or if it is rendered anonymous. And so what are the issues? No, what are some of the issues that are around this topic? Well, first, as I say, there's hardly equality data collection legislation, and the legal obligations that to collect data remain quite limited in all EU members, basically relying on the work of equality bodies monitoring inequality and to publish research and report. There's certain exceptions like Ireland, luckily. But there's also another characteristic, another issue is the data collection has not been standardized at the regional and even at the national level. And since there is such a discrepancy between national and European methodologies, this limits not only the access to data for various minority groups, but also it renders the European data collection much less reliable and comparable. Furthermore, few countries operate comprehensive systems that or have a coordinated approach to collecting and using equality data that will actually help uncover all the inequalities based on racial and ethnic origin. And if it is available, such data are often not up to date, or they are frequently they have frequently a limited scope. They are not transparently available in the public domain, etc. And as you mentioned already, Raymond, we know that data collection is permitted, but actually in practice, is not undertaken on the grounds of skin color or racial origin, and there is indeed a great variety of data is collected on language, place of birth, on migration background as proxies, but they have a common characteristics that these categories are actually as a general rule being adopted, but without the community consultation. And not to mention, again, the lack of trust from racialized communities to share their personal data to institutions due to past and present abuse of their rights, as racial communities by the health institutions. Well, I want to finish with kind of a positive note. I don't want you to lose the hope yet. So there are actually some good practices that we can hold on to. And one of them is, for example, coming from the European institutions, the guidance note, the collection of and use of equality data based on racial and ethnic origin, which was published in 2021. This is a good example to try to guidance member states to coordinate an approach to collecting and using equality data. Of course, the Fundamental Rights Agency have a wide extent of publications of work on such matters. But also, fortunately, we have key experts today, in the field here today that will share further insights. And I think that's the aim of today. We will hopefully see today some examples and answer to questions such as how equality data in the area of health related to racialized communities is collected, and with what purpose. But also another question is, what are some of the barriers that researchers face or organizations face or identifying such data collection? How can we overcome them? Are there any further good practices from which we could learn and try to apply in our own member states, maybe, or institutions, to improve such data collection, including comparability, accessibility, and transparency? So what I hope from today is that by the end of this webinar, we will have some answers focused on improving the collection and use of quality data and recommendations on how this might be achieved. So thank you very much, and looking forward for the discussions.
Thank you very much, Daris, to provide the legal framework, to have a clear overview of some of the barriers, and indeed to end with a positive note, looking at the actions already undertaken. And we will hear also from Eurostat later during this webinar. And we are now actually going to our next speaker, and from whom we will hear kind of from the OECD context. So we have Kate de Bienassi, health policy analyst at the Organization for Economic Cooperation and Development, OECD. And Kate has experience in healthcare policy, clinical research, and program evaluation. And we'll talk about the availability, the use, and analysis of data for exploring inequalities in health in the OECD context. Kate, please, over to you.
Great. Well, thank you very much for the introduction, Raymond, and it's a pleasure to be with everyone today. So again, my name is Kate de Bienassi. I'm with the Organization for Economic Cooperation and Development, and today I'll be discussing the availability, use, and analysis of data for exploring inequalities in health in the OECD context. So a bit of motivation. This has been an important topic for the OECD Health Division for some time, but the COVID-19 pandemic in particular has really increased country interest in addressing and mitigating inequalities in health that has been driven by the COVID-19 pandemic and related policies. We saw through the COVID-19 pandemic that disadvantaged groups, for example, people with low incomes, low education, ethnic minorities, and immigrants, faced an elevated risk of infection, hospitalization, and mortality from COVID-19 than more socially advantaged groups. But in addition, we saw that measures taken to control the spread of the virus, in particular, had a disproportionate effect on those already experiencing social health inequality, and that existing inequalities have been widening. This includes higher rates of mental distress, foregone care, and disruptions in routine care. So I've included a few examples of how different countries have been approaching this. For example, there have been measurements of inequalities and changes in life expectancy by race and ethnicity in the United States, by country of birth in France, and by deprivation area in the United Kingdom. But as Raymond said in his introduction, the comparability is still quite limited. So this is a challenge that we're looking at to see how we can improve the standardization of this data. Equity is a core component of the OECD Health System Performance Assessment Framework. And so it addresses a number of issues, including the results of clinical care. This includes the domains of quality, effectiveness, safety, and person-centeredness of healthcare systems, access and cost and expenditure. But it's also something that extends beyond the healthcare system directly and also addresses issues of non-healthcare determinants of health. And so you can see here where it fits into our measurement framework as a core and cross-cutting component. I thought I would take this opportunity to highlight a broad portfolio of work related to inequalities that the OECD already has to build on, because there are a number of resources already available. So the first is Health for Everyone. This is a report that was published in 2019. It looks at issues related to determinants of health and access to health care, and conducts a number of subgroup analyses based on income, gender, and education level. We also routinely report disaggregated information in our Health at a Glance flagship report series. This typically includes disaggregated data by location, urban versus rural areas, education level, income level, and gender. We also report a number of health indicators through information collected through our OECD work at the subnational level, and this is reported in the OECD regions and cities work, and I will touch on this a little bit more shortly. To highlight to everyone, a very recently released publication on socioeconomic and ethnic inequalities in COVID-19 outcomes across OECD countries. This is a new working paper that was released within the last month that explores some of the inequalities across OECD countries and COVID-19 outcomes in particular. And then finally, another new release, which is the OECD Cancer Inequalities Country Profiles, which has been developed with the support of the European Commission and looks at the scope of inequalities in cancer risk factors, accessibility, quality, and costs across a number of factors. So while there is quite a bit of work that has already been conducted from the OECD perspective, we did a quick mapping exercise recently to assess what analyses have been conducted in which areas of common health indicators and by which factors. You can see here that across the common factors, the localization data has been linked to health statistics data in a number of common indicator sets. Other areas that are commonly linked include income, education, gender, and age, but these are a bit less comprehensively analyzed and more challenging in terms of the conduct of analysis. And then you can see on the left-hand side in the areas of race and ethnicity, country of birth as a proxy for migration status, and disability, we have really limited data at the moment in terms of our routinely reported OECD indicators and the ability to disaggregate this information along these factors. So to support and increase the ability of countries to disaggregate information, we conducted a survey with OECD countries to get a sense of whether they were technically able to conduct analysis by subgroup for specific health statistics indicator groups, meaning that there weren't particularly burdensome legal barriers or technical barriers that would prevent them from conducting this analysis, and if it would be feasible. So that is if it would be something that they would have the capacity to do. And we looked at common indicator sets collected through our health statistics working party along the domains of citizenship, migration status, education level, employment, housing, comorbidities and disability, income, language, location, provider and coverage type, that is public versus private, and race and ethnicity. We got survey responses from 29 countries, and there's two numbers in each box. The first is the number of countries that report that it's technically possible, so they could, in theory, do it. And the second number is if it's feasibly possible, which means that they could do it without the undue, within the resources that they have. The boxes that are highlighted are where more than 50% of countries reported that it was feasibly possible. And so you can see that there, within this set of indicators, which relates primarily to contextual factors, utilization of resources, there's only a few indicators at the moment where more than half of reporting countries are feasibly able to report disaggregated data along these lines. Primarily, the additional data could be reported based on location, but again, we have very few countries that are able to report on race and ethnicity. Countries that indicated that they could, either technically or feasibly, conduct these analysis for one or more of these categories included Australia, Bulgaria, Canada, Hungary, Ireland, Israel, the United Kingdom, Costa Rica, and Japan. So it doesn't necessarily apply to all of the sets of indicators, but they at least indicated that they could potentially do this for one set or more. So these indicators relate to healthcare quality and outcomes. So these are more the results of clinical care. And we have a different set of responding countries, 23 countries that responded to this data. And again, we have a number of countries that are technically able to report, particularly related to location and provider and coverage type. And we do have a number of countries in the dark orange where more than 70% of countries indicated that they could feasibly report more broken down analysis on these indicator types. But again, particularly in the area of race and ethnicity, only a few countries indicate that they're able to do this. And for countries that responded that they could for one or more of the indicator sets, these countries included Switzerland, Germany, the Netherlands, Australia, the United States, and Israel. So as I said before, one of the things that the OECD is exploring is opportunities to link information on health outcomes based on location with other information, particularly related to some of the factors that were explored in the previous slides. And so to do this, we would look at health outcomes indicators and link them to information from other data sets. And we would use this, do this using data from our Working Party on Territorial Indicators, which collects data at the subnational level across OECD countries. They currently report a number of indicators, including life expectancy, mortality by age and cause of death, obesity rates, and hospital and doctors density, as well as a few indicators collected from geospatial resources and also from web scraping with high frequency, particularly related to COVID-19 outcomes. In the next round of data collection, we're including 2 new indicators that will be available at the subnational level. These include information on hospital discharges, which will be the first health outcomes indicator, and nursing density. So there's quite a bit of work that needs to be done building across the analysis that has already been conducted. I think that we see a particular opportunity relating to furthering the availability of health statistics and healthcare quality and outcomes indicators by location, because we can then do this linkage based on some sort of localization index to then account for other factors such as income, education, comorbidities, citizenship, for example. But we also see the need to support country policy development, and in particular, supporting countries to expand their measurement and data linkage on priority topics. And some of the core issues that we see based on our analysis included race and ethnicity, country of birth, income, education, as well as information on sexual and gender minorities. So we see the need to support countries to build this information into their health data infrastructure so that it can be used to support analyses in the future. So thank you very much. I'm happy to take any questions, and thank you again for the opportunity to present today.
Thank you so much, Kate. Well, actually, a lot of questions already come to mind. And to the audience, if questions also come to your mind, please do not wait to already drop them in the Q&A so that they can be picked up later on during the Q&A session of this webinar. So now we move on to the next speaker and get yet another perspective on the collection of equality data in a real life setting. So we're going to hear from Vital Katikereddy, Professor of Public Health and Health Inequalities at the University of Glasgow. Vital works on the social determinants of health, on reducing health inequalities, and investigates healthy public policy. Today, he will speak about how to overcome some of the barriers when it comes to the collection of equality data. Vital, please, the floor is yours.
Excellent. So real pleasure to be able to speak to you today. So much of what I'm going to cover in this short presentation builds on many decades of work by many colleagues to try to improve the collection of ethnicity data. So there's a long-standing evidence base, and the particular points I'm going to cover are largely described in a bit more detail in this set of recommendations that we've made previously. So to try to understand what we need to do, it's helpful to first think about what might be some of the common challenges to collecting ethnicity data. A common perception, and arguably a misperception, is that patients are not willing to provide ethnicity information. Generally, the evidence base suggests that's not the case. However, what is important is that when people are being asked about their ethnicity, the information is being asked for in a sensitive way, and there needs to be a proper explanation of why ethnicity data are being collected. People also need to be reassured that the data are going to be used to benefit ethnic minority groups, and not for other reasons. So other challenges that actually are often very important when we look at the literature relate to healthcare staff. So often healthcare staff feel a reluctance to ask about ethnicity, and they might lack confidence to be able to do it in a sensitive and culturally appropriate manner. And it's important to remember that by healthcare staff, I'm not just referring to health professionals. So often receptionists and other staff are particularly crucial. There's also an issue about staff not having knowledge about the importance and use of ethnicity data, and a misunderstanding of what ethnicity means, and commonly a confusion about how ethnicity might be coded or categorized. Of course, at the moment as well, as we're moving out of the COVID pandemic, there's a lot of pressure on healthcare staff in many health systems. So this is another important challenge. So there needs to be the time made available for staff to be able to invest in this. But thinking more broadly, there's a number of more structural challenges as well. So often there's a lack of central support, so both in terms of training, but also in terms of the infrastructure required to collect data. There may well be variable processes for collecting ethnicity. So for example, differences in how ethnicity is coded across different parts of the health system, even within a single region or within a single country. There are important governance barriers in many situations to actually conducting data linkage as well. Despite data linkage often being particularly important to studying ethnic and racial inequalities, since many of the drivers of these inequalities in health lie outside of the health system, and so benefits from linkage to other data sets. Just a note though, I've mentioned this issue about the variable processes for collecting ethnicity. That's not to suggest that we need a totally standardized system of collecting ethnicity and standardized codes across countries. Actually, that may be, and often is, inappropriate, because different countries have different compositions of ethnic groups and different important social and historical reasons for collecting ethnicity in a different way. What is needed, though, is careful thought about what is the most appropriate way of categorizing ethnicity and doing that in conjunction with minoritized people. So when we're thinking about trying to improve data collection, it's not just about the actual process of collecting data, it's also about making sure we're working with minoritized communities, and they should be at the heart of the process. through their involvement, it can help in defining how ethnicity is being collected, how it's being coded, what the ethnic categories are that you're using within your local situation. And often public involvement is very important to help produce effective training for professionals as well. But once we've got high quality data, we also need to ensure that the data are used to create impactful analysis, and that in turn will help maintain the trust of the public. So a few more kind of specifics about addressing barriers. So I've tried to emphasize this issue about involving minority ethnic communities throughout the data lifecycle process. We should be trying to collect ethnicity information routinely within regular processes within healthcare. Ideally trying to have standardized protocols for data collection, but that are well thought out and publicly informed. There's an important role for staff training, and we want to, given the burdens that staff are under, we want to try to avoid repeated questioning of patients across lots of different parts of the health system. So thinking about linkage to make that more efficient is important. It's also really important that we maintain trust in data systems, so ensuring there are strict confidentiality controls and that there's a clear separation made between collecting data for health purposes and for other purposes which may not necessarily benefit the people who are providing the data. Other important aspects of things, of concrete actions, are trying to make sure we're regularly reporting on data quality and then taking action to improve that data quality, developing minimum standards for health records, especially electronic health records, and trying when we can to bring in broader perspectives about the underlying drivers of ethnic and racial inequalities, including, importantly, the social determinants of health. Once we've carried out our monitoring and our research and analysis, it's really important that the value of data collection is made clear to the public, and in particular to minoritized communities. So to finish with, I'd just like to give you a slightly more concrete example. So Lothian is an area in Scotland, the area of Edinburgh and its surrounding regions. So they introduced an initiative back in around 2011 or so to try to improve recording of ethnicity. And as you can see, compared to the rest of the country, they rapidly increased collection of ethnicity information, and they identified key factors in their success that included the training of healthcare staff, but importantly also senior level buy-in. So the managers in charge of the healthcare system were emphasized its importance. Unfortunately, after this improvement, which was great to see, the data weren't always consistently used, so that success wasn't retained. So this emphasizes the importance of not just collecting data, but also ensuring that data are analyzed once they're available. So thanks very much.
Thanks a lot, Vital. Very, very interesting. As Daris mentioned in the very beginning, we have a representative from the Belgian equality body. So we're moving on now to Rachel Warniers. She's a policy advisor at UNIA, the Interfederal Center for Equal Opportunities. So UNIA is an independent public institution which fights discrimination, promotes equal opportunities, and protects fundamental rights. And Rachel will today speak about building an equality strategy here in Belgium. Also, I say here because I'm based in Belgium. But please, over to you, Rachel.
Thank you for the introduction, Raymond, and it's a pleasure to be able to speak to you today. So I'm Rachel, and I work at the research unit at UNIA. And today I will talk to you about how we are trying to build an equality data strategy in Belgium. So we started in 2020 with a project called Improving Equality Data Collection in Belgium. We did this project in partnership with the Equal Opportunities team of the Federal Public Service for Justice in Belgium. And it was a one-year Belgian project that was also co-funded by the REC program of the DG Justice of the European Commission. And we worked on this with 3 colleagues at UNIA, and we were supported by 2 colleagues at the Equal Opportunities team of the Federal Public Service. Actually, the title of our project really says it all, Improving Equality Data Collection in Belgium. We had the aim or the objective of strengthening the collection and use of equality data in Belgium. Why did we want to do this? I won't go into the importance of equality data because I think it's clear now by the presentations before why it is important to have equality data. But we noticed in Belgium that there are quite some equality data in different domains for different discrimination grounds. But in other domains, for example, in health, we lack data. Moreover, the landscape was very fragmented. Data were not accessible. It was not clear where data could be found. And it was in this way also hard to find and use the data. Moreover, in Belgium, different data producers also use different definitions for in their data collection, which makes comparison even more difficult. We already talked about comparison between different countries, but in Belgium, this is also a very difficult question or a challenge within the country, also because of the different levels of governance that use different definitions. So we aim to strengthen this. Because it was a one-year project, we couldn't be too ambitious, and we focused on equality data sources for 3 groups of discrimination grounds. And the first group were the so-called racial grounds, as they are called in our legislation. The second group was religion and philosophical conviction, and the third group was on sexual orientation and gender identity. So what did we actually do? First of all, to improve the situation, we wanted to have an overview of what exists already in Belgium and what is actually lacking. So our first objective was to map all existing equality data sources in Belgium. And second, we made these data sources more accessible to the broad public by and to important stakeholders by creating an online data hub where this mapping was freely accessible. So I posted a link here on the slide, but can also maybe post it in the chat. It's the link to our online data hub where all equality data sources can be found and can be easily selected, selecting different domains and different grounds. And then as a third step, we also analyzed this mapping. We identified the gaps in equality data and we wrote recommendations. We have a report on our website, an English version of our report, so you can download it there. I can also post the link or share the link later. Unfortunately, our data hub is not available in English, but only in French and Dutch. So in this report, we exposed several gaps in Belgian equality data, and we did recommendations on how to improve the situation. And one of the gaps that we pinpointed was a gap of equality data on discrimination, inequality, and racism in the health sector, so the focus of today. And this again, because we saw that there was a very fragmented data landscape. So there are some data gathered, but they are not centralized. Different definitions are used. And one of the main problems, of course, that also in Belgium, in the health sector, there is no collection of data on ethnic and racial origin of patients. Often administrative data or proxy information such as nationality and country of birth are used, but this is also sometimes problematic, as was already mentioned before. So maybe I want to say a little bit more about how did we proceed to achieve these objectives. This project was actually a lot based on the guidelines on improving the collection and use of equality data of the Fundamental Rights Agency, or the subgroup on equality data of the Fundamental Rights Agency, which was already mentioned as well by Daris in the beginning. They have very good guidelines that we try to follow as much as possible. And one of the guidelines that we followed was to use a participatory approach. This is also in line with the human rights-based approach to data. So we established advisory committees with stakeholders from civil society organizations and public institutions, but also from academia. And they guided the whole process through meetings. They gave us input and feedback. Next, we also distributed a survey very widely on Belgian equality data on different stakeholders, and we did expert interviews. And then lastly, for our mapping, we used a mapping tool that was developed by the Fundamental Rights Agency, which can also be found on their website. And we used this mapping tool to map equality data sources. Of course, we adapted the mapping tool to the Belgian situation, but it was a very useful tool to start from. Now, this project was finished in 2021, as it was a one-year project. And I want to tell you a bit more about the ways forward that we see. So first of all, of course, the creation of the online data hub, it was a lot of work, but the truth is that it's actually only the beginning of the work. Of course, it's very important to keep it up to date, and that's something that we are trying to do now. But moreover, it's also only the beginning of the work because, like Vital just mentioned, measuring inequality is essential, but it is not sufficient. Equality data should be used as well. And so we want to try keeping or creating more awareness about the importance of equality data and the use of equality data in policies. Another challenge that we encountered during our project is that there's a lot of misconception about the legal framework and what can be done with personal data. It is often used as, we encountered many misconceptions in the sense that people use a legal framework as a reason to not collect equality data. So we think it's important as well to raise more awareness on this and spread more clarity about what can be done with the legal framework. Then, of course, we also want to use the gap analysis for developing a long-term strategy, especially in the case of the health sector, for example. We want to really, or we are lobbying for more data, equality data in the health sector. And all of this is coming together now in our follow-up project that I can very happily announce now that we started in January. It's the Improving Equality Data Collection in Belgium 2 project. And actually it exists of 2 different parts. And in the first part, we are studying the feasibility of using self-identification for ethnic origin in Belgium. As it was already mentioned, it is a good practice, and it's also something that comes back in the human rights-based approach to data, but it's not often used in Belgium in different domains. So we are setting up a participatory process with the involved groups, the groups that are involved in the question, to look into how we can standardize self-identification and how it can be used in Belgium, in what contexts, for example. And it could be also something that could be improve equality data collection on ethnic origin and race in the health sector in Belgium. And then in the second part of our project, we will continue mapping of equality data sources, and we will add them to the data hub. And we will focus more specifically now on equality data sources for disability. We keep up the work of spreading more awareness in Belgium, bringing different stakeholders together and doing a participatory approach to it. So people realize the importance of equality data, especially also in the context of the health sector, where there is, for example, in Belgium, a patient's rights legislation. So it is actually a very good tool to show to people how important it can be to gather data in order to show where the data or where their rights are not met or where there's inequality in the protection of their rights. So thank you for your attention, and I give the floor back to you, Raymond.
Thank you very much, Recio. And actually, thank you to all the speakers, because we are perfectly on point with time. And that is great, because we go to the Q&A. And that's actually an important part for us to engage with, as a network, with a wider audience. If I can just squeeze in one quick question to Recio. You mentioned the follow-up study. Is that again with European funds or Belgian funds in this case?
This time it's not with European funds, but only with Belgian funds. So we are co-funded by the Federal Public Service for Justice in Belgium. Okay, which is great. Then you have the political support from the country. Yeah, exactly. Okay, so then now it's a real pleasure to introduce to you Jacqueline Bowman-Bussato, who is head of policy at EASO, European the European Association for the Study of Obesity. Who will be moderating the Q&A session. So I'm not going to lose any more time and head over to you, Jacqueline, please.
Okay, thank you so much, Raymond. And thank you to all of the speakers, because there have been some really clear, I would say, clear consensus as to what's gone wrong, and also where we might want to focus our efforts in terms of understanding the system. So there have been a couple of questions already within the chat. So I'm going to kick off with, I think, what's called the elephant in the room. And Thomas, thank you very much from EPHA. Your original question was to Daris and/or Kate, but actually I'd kind of like to hear from all of you, because I think it's a very relevant point. So the question is, a number of EU member states do not collect data based on ethnic identifiers, citing different concerns. So do you have or what ideas, because do you is an easy yes or no, so I'm going to ask you to think, what ideas do you have on how to address these concerns so that actually this kind of data can still be collected? Be as precise as you can. Let's kick off with Daris and Kate, and then others come in. Daris.
Yes, indeed, it's a good question. No, it's I mean, it's definitely one of the obstacles that have been highlighted. No, the lack of sort of political will, to collect this type of data. We have identified through our work how different actors have anyways take the initiative when there's a lack of initiatives by their own by the member state. For example, there are initiatives carried out by CSOs. There's one actually very interesting from EO2, Each One Teach One in Germany, which is the project AfroCensus have been gathering this type of data on the experiences of discrimination by Afro-descendants, including health, access to health. The same, I think, is being carried out here in Belgium by, I think, an organization is Sanka, I don't remember now well. So that's one possibility. Of course, it shouldn't be. They shouldn't really have the burden to.
Okay, this is exactly what I was
exactly. Should be have been, if they have the burden, at least it should be funded sustainably by the governments and not ad hoc. This happens very often, that they just provide funding just for a year and then the project stops. And that's one. Another one also. Also there's possibility to report the lack of collection of statistics to court. I think that there was I think it's still pending a case in one of the EU treaty bodies. I think it's in Czech Republic, about how they are not implementing one of the judgment with regard to segregation and the school, being that they are not collecting the data the statistics based on racial and ethnic origin, and therefore, they cannot really provide the information. The state is very, of course, it's very interesting for them. So that's another. As Recio already mentioned a couple of them, there's also need to be raising awareness of the importance of such equality data, so that we can also, kind of push the member states to do it. And obviously, like, create this kind of organizing an event, a network, a platform, including not only CSOs but also representatives from member states, national statistics officer, data protection officers, so that we can exchange actually what are the needs. How can we improve the collections data? How can we do it? How can you implement, as Beetle said, the collection of this data routinely, in our institutions? So yeah, those are some ideas.
Okay, I've picked up on a couple of things, which I'm going to bring in Kate on. So, I mean, it's almost as if the devil is in the detail, isn't it? Because in effect, you're trying to say, is this something that we want to use a carrot or a stick? So the carrot being incentives for national authorities to actually collect this data, and bringing in Kate as OECD. I've spoken with some of your other colleagues in public health, so Michele Cecchini, who very much said at one point that OECD is a data user and also a data generator. I see OECD as a kind of bridge between basic data into policy evidence, put it that way, into practice. So when you hear points about incentives or sanctions, and also the points about if you like, as Unia was pointing out as well, when you have points about we need to do this in a collaborative manner, OECD works with a number of stakeholders in order to, should we say, package, repackage, generate policy evidence. So what are the ideas that you can bring to the table to try and sort this out? Is it carrot? Is it stick? Over to you.
Sure. Well, thanks a lot. It's a good question, and I will put a disclaimer at the very beginning that I won't know all the answers. But I think one of the things that we see from the OECD as a publisher of international benchmarking data is that really the first attempts of getting the data out are always very controversial, but they don't. In some cases, especially with our pilot data collections, our more exploratory work, the function is multifold. So there's, of course, the objective of having information for benchmarking and comparisons, but at the very beginning, often it's a signaling exercise to identify what countries are actually able to produce the data needed and to share best practices. So I think in terms of what kind of the OECD perspective can offer is the sharing of best practices. So I think, as was cited by Daris, that there's all sorts of different interpretations of the GDPR that some countries are able to handle, some countries aren't. I think there's very similar concerns about the legal environment or the data linkage environment. But some countries are able to address them, and I think there's a lot that can be said for sharing the best practices of the countries that have. But I know it's a limited number of countries at this point, but of course, you have to start somewhere, and just getting the data that we do have out there, I think, can have a mobilizing effect for other countries.
Excellent. And before I come to the UNAIDS question, I'm going to bring in Vital here, because actually you're a bit of a bridge. One of the points that you were making, and I think this is clear, again, work that we're doing within EASO, we're looking at, indeed, how do you collect data, in our case, that goes beyond BMI to reflect the realities of the disease of obesity. Now, one of the points that you mentioned, which I really picked up on, was the need to train professionals. Now, for us, certainly in the obesity chronic disease implementation space, there's a massive debate going on in terms of at what point do you need professionals to be trained? Is it only the health professionals? Is it particularly when you're collecting data for registries, and in this case, to look at health inequalities, or to look at inequalities in terms of access to treatment? Are you suggesting that it's the hospital managers, it's the IT teams? Who do you need to be trained in order to buy in to actually collecting relevant and meaningful data that can be used? And also, at what stage? Over to you, Vital.
Yeah, so the simpler part of your question, who do we need to train? So I would say that it's not just the professionals. So we're not just talking about doctors, nurses, physiotherapists. In many ways, actually, it's probably as important, or maybe even more important, to be training the receptionists, the administrative staff, and so forth, who are often collecting this type of information when a patient first engages with a health system. There is certainly a case for making sure things like undergraduate curricula are provide training and education about ethnic and racial inequalities and why it's important to collect ethnicity data and so forth. But in reality, actually, we probably can't rely on that to really drive change. In terms of what we need to train people about, so it's partly about actually many staff are quite uncomfortable speaking about ethnicity. And so it's partly to give people confidence in how to engage with these issues in a way that they feel comfortable with. And so it can often be about, firstly, understanding what ethnicity means, what we're asking people to do and why, but also the actual practical thing of how do you try to explain to a patient what information you're trying to get, and how do you ask that question in a sensitive way. So there's the more making the case for data collection, but also then the very practical, how do you ask a question?
Yep, exactly. And it seems as though you're in the hot seat again, Vital, because someone else has asked actually an ongoing question, which is essentially from Simona Stefanescu. She's asked generally, and also specifically to you, agreeing the need to maintain the trust in data collection. But of course, most of the time it takes a long time, yet all of the points that we've raised. And then her real question is, so training and better communication is one of the solutions, but also how do you secure the link between, as almost makes a business case for the, should we say, health system users who need to give this information? How do you make the business case for them to actually want to hand over their data, and also the benefits of reliable data collection?
So I think one of the things that's been quite striking during the COVID pandemic has been actually by presenting the evidence of ethnic inequalities. So I'm based in the UK, but I think the UK has been probably an outlier in actually publishing high quality data on ethnic inequalities and COVID. But by actually making that the use of data clear to people and actually showing, look, it is changing debates, it's changing how we understand health needs, and then also seeing how actions might follow that as well, it is possible to do. I think one of the important things to do is to actually work with minoritized communities to try and make sure we're answering questions that are important to people. So that's why I think there's a risk that if initiatives to improve data collection are seen as very top-down and only top-down, then they're often become disconnected from what communities themselves are really interested in. So I think that it's important that we make sure that when we are using data, including linked data, we actually speak about the benefits of allowing such systems to shine a light on inequalities, to better understand them, and also to take action.
Yeah, absolutely. And I think I've got about 2 minutes left before Raymond says move on.
No, make it 5. Make it 5.
Oh,
Jacqueline.
thank goodness, thank goodness. Okay, so I'm actually going to bring in our colleague Rachel from Belgium, where I certainly sit. So I want to hear more from you, Nia, as well, in terms of, you know, how, because one of the questions which, having lived in Belgium since '96 and in Brussels and Flanders, I think, you know, I have stories, put it that way. But what I would actually like to know, I was really interested when you, well, the whole thing was great. But one of the challenges I've certainly faced when speaking with, in the past, with the, should we say, the tech side of all of these data hubs and information out there, and particularly now that in Belgium, as you say, we're going through the revision of the patient rights legislation, which, by the way, is not only for Belgium. There are a number of countries who are implementing this as well. But literally, how are you really able to involve, should we say, the racialized communities? Because, you know, the other day when I was speaking with Frank van den Broeke, our Federal Minister of Health, and I asked a similar question related to obesity. And I said, well, you know, how are you able to engage with the obesity community from the lived experience perspective? And his answer normally was, well, we deal with the formal stakeholder organizations, for which until this point there were actually no representatives of lived experience from the obesity community. So my question is for you, Nia, how are you able to actually really have a meaningful voice for people from racialized communities and ethnicities? Because, for instance, where I live, we have over 180 nationalities, and it's not Brussels, it's in the middle of Flanders, you know. And then the other related to that is, how do you actually make sure that the general population is even aware of the data hub, which is fantastic, but the tech people always tell me, well, it's there, good luck. So how are you able to answer all of that and give us impetus for other countries?
Thank you so much for actually 2 very relevant questions, and difficult to answer, because I think it's 2 of our 2 of the challenges really that we're struggling with at the moment, let's say, and we struggle with in the first project as well. So with regard to the first question about how do we really interact with racialized minorities themselves. So in the first project, we mostly worked through civil society organizations and stakeholders. So we definitely have some work to do there. In this second project, and especially in the focus or the study on self-identification for ethnic origin in Belgium, we try to deepen this participation. So we have, again, advisory committees with civil society organizations, but this time we would really like to go or organize focus groups, for example, with people from communities that are often also, we will ask, of course, again, the help of civil society organizations. So we will link with them, or we will need their link to the racialized communities themselves to involve them in the project. but it's definitely something that we are looking into at the moment to how can we really raise this involvement even more and not only work through civil society organizations and important stakeholders. But that's how we worked in the first project. So it's definitely a challenge that we encounter as well. And at the moment, we're really looking into organizing focus groups in this study. And then with regard to your second question, yes, I totally agree. The Data Hub, it's of course, it's a very nice tool that we developed, but it's not accessible for everyone, and it's not. There are some issues there. We did a lot of efforts already to make it as accessible as possible, but it's one of our objectives also of this project to look into how can we make it even more accessible, especially because one of the target groups of this project is also people with disabilities. So for them, there might be additional barriers as well. So it's something that I can't really answer at the moment, but it's something that we're looking into.
Yeah, absolutely. I completely agree. We can continue that discussion offline. I have ideas, put it that way. Okay, so then, of course, hot topic within the EU. Anyone put their hand up, answer. Commission I see is on the line as well, feel free. It's all about the EU health data space. So how can we actually integrate the findings and the work that's going on in terms of collection of equality data into the European health data space legislation? And I know Eurostat's already on the call, so that might be a good segue into the rest as well. But at the moment, I think I see Kate's hand going up. Over to you, Kate, from OECD.
If I can shortly interrupt, can we have one answer from the panel? And you also promised an answer to Triantafilos. So if we can take these two questions and then we go to the next part.
Yes, so Kate, that's you.
No hand, that must be a mistake. Apologies.
Okay, so I think you've just lucked out, and we go on to the UN AIDS question. Yes, Raymond?
Yeah.
Okay, so let me just scroll back up. And it was okay, so basically it was that working with just a minute. So working with UNAIDS to develop an indicator to measure gender responsiveness of HIV services, where the unit of data collection and analysis is the facility rather than the individual or patient. So they'll be recommending countries to undertake disaggregated analysis by location, type of facility. Would you have another variable and or indicator to suggest that could be used to address inequalities from a health systems perspective? So this is absolutely going to be relevant for HIV and for anti-racism. So panel. I have Vital looking like you're about to say something. Yeah? Nope. Would you like to give it a shot? It's a tough question, but I think basically what it boils down to is we tend to take, if you like, disaggregated personal, so the individual level. But one of the big discussions in health systems performance assessment is health system transformation. So I think I would twist that question slightly and say, A, is it worthwhile doing it in terms of a systems level? That's the first part of the question. And B, if we do, how can we actually take the location into account? Is that basically what you wanted to say, the person who was asking the question? I'm hoping that was a yes. But I've got blank faces. So I
recognize the question is not a straightforward one, yeah?
No, it's not at all. But I think actually that's a really good point, that we need to take that back in-house, so to speak, because it will come up again when we get to, as Raymond will say, when we actually get to the finalization of the draft The draft, yeah, because it's literally one of the questions that we dealt with at the beginning, actually, particularly related to anti-racism. It was, should we be dealing on the individual level or should we be dealing on the system level? So I think that's really a good example. Oh, Vital.
Yeah, sure. So I mean, I can say something about this. So
Thank you.
clearly, racial and ethnic inequalities in health reflect structural and systemic issues. So by trying to change behaviors of individuals, we're not going to solve racial and ethnic inequalities in health. So it is really important to think about the systems of, in terms of health systems, but also thinking about economic systems, thinking about education systems, and so forth. So, for example,
short example, Vital, please.
Sure.
Yep.
Okay.
Yep.
So citizenship and rights to healthcare is a kind of obvious example. So this isn't about the actions of specific individuals or interpersonal racism, if you like, one person discriminating against another. That does happen, that shouldn't happen, and we do need to address that. But actually, these broader structural issues are really important and we can't afford to ignore them.
Great.
Thanks a lot.
It's like a pyramid. Can I bring in Kate very briefly, because I missed your hand, Kate.
I saw the hand.
Yes, no problem. It was a real hand this time. Apologies. But just to note, I think that these are great points, and it also deals a little bit with what is possible and feasible within the system. So from the data that we showed, a lot of the information on healthy behaviors, health enabling environment, and risk factors, you're able to get to more information on some of these factors for disaggregated analysis because it's through survey data. And linking the survey data then to clinical data, it's much easier at the more systems level. If you can link it to a specific healthcare provider area, that's even better. But I think that there's also a pragmatic reason to consider those kind of indicators.
Okay, excellent. I have so many other questions on that, as I'm sure so do others. We'll have to continue it offline because I see that Raymond is about to say, move on.
I am. Okay, thanks a lot. Thanks a lot for the engagement. And actually, that is one of the key parts of the webinar where we have run out a little bit. But I'm more than happy that actually that was my time and I can finish, the webinar in 1 minute. So no worries, we still have the 10 minutes allocated. And we just had the mentioning from Daris about involving the various stakeholders, including the data collectors. So I'm very happy that we have some EU level data collectors, it was you, Kate, mentioning also the signaling function. So I think it's really great that to have Eurostat colleagues part of the webinar as well. And also we have our colleague from DG Sante. So DG Sante is actually hosting the thematic networks and making these webinars possible. So we are very thankful for that. So very quickly, we'll have Irene Athanassoudis, Policy Officer at DG Sante. And colleagues from Eurostat, we have Aura Lulescu, who's Deputy Head of Unit working on, maybe you could explain exactly what it is, because I don't know, the reinforced role of social indicators and early indicators of inequalities. And Lucien Agafitai, who's a statistical assistant working on statistics in health, income and living conditions, quality of life, and health interview survey. So please, over to you. I think first, Irene.
Yes, thank you, Raymond. I will be very brief because we have got so interesting information that I don't want to bother you with formal language from Commission. It was really interesting what we have heard this morning in the webinar about the quality data and how crucial they are for describing and analyzing the state of equity. It's a fact that EU member states don't have all the same ability to monitor health inequalities, and the underlying determinants, social determinants, their ability varies a lot, and most countries lacking a wider range of indicators which are important to understanding the social determinants driving the health inequalities. I am really grateful to hear the work UNIA is doing and also the important role of equality bodies in connection with civil society organizations. And saying that, I would like to inform you that in last December, the Commission adopted 2 proposals for a Council directive on minimum standards for equality bodies. One of the 2 is in the field of equal treatment between persons in matters of social security and in the access to and supply of goods and services, and this of course includes also healthcare services. And I have heard by my colleagues in DG Just that the negotiations with Council have started and are in good progress. The aim of this proposal is to help member states ensure that equality bodies have the necessary resources to fight discrimination on the grounds of sex, gender, race, ethnic origin, etc., disability, sexual orientation. And in this recommendation, we have specific articles 14 and 15, which is about monitoring, reporting, planning strategically the activities. And furthermore, the proposal stresses the importance to raise awareness on the role of equality bodies and on how citizens can access them to exercise their rights if they experience discrimination. Of course, in my role, I have to remind things that already have sent in a very intelligent and nice way. For instance, no data collection activity should create or reinforce existing discrimination, bias, or stereotypes, and the data collected should be used for the benefit of the groups they describe and the society as a whole. Yes, data on ethnicity are particularly sensitive. We don't have them. They could be very useful. But we have seen from Catherine OECD analysis that we don't have so many countries that they are ready at the moment to do a progress on that. But still, personally, I think that we need them. Of course, all this collection of disaggregated data by personal characteristics, as we have said, disability, ethnic origin, sexual orientation, should be done always on a voluntary basis, giving the possibility to the concerned people to not answer if they don't wish. And of course, here I will join all the ideas of explain to people, making clear why we need this data, how we can use it, train the personnel, health professionals, or even in the reception of the hospitals. All that are very, very important information we got this morning. Happy to hear that the guidance, the document guidance note for the collection and use of equality data is something that organizations are using and find it useful. As DG Santé, what I can say is that in a number of EU equality strategies adopted in the last 3 years for Roma, for LGBTI people, for people with disabilities, and also the EU anti-racism action plan, DG Santé has committed to include data about these people in the EU Cancer Inequalities Registry. Catherine has mentioned this is a flagship initiative under the Europe's Beating Cancer Plan developed jointly with OECD and the GRC, Commission Research Center. we see how difficult it is to find the data and enrich the cancer inequalities registry, but certainly we have to try to do it. And from the people in the panel, but also from others that have joined this webinar today, if you are aware of such kind of data, literature in this field, I mean marginalized communities and cancer, we would be grateful to receive. We have found data for United States or Australia, but in Europe these are very scarce. Very little even in existing literature. We have already started with the people living with disabilities. We have a study, announced a study that it will look into the collection of data for these people to access to cancer screening and care. And we are in the process of evaluating the technical offers. And of course, this will be done in a participatory approach, and we will need all the interesting organizations to join this effort. And also regarding the LGBTI, and I stop here.
Okay, because otherwise the time for your colleagues will
yes,
get very
I know,
short.
I know.
Yeah.
And for the LGBTI people, in cooperation with the Fundamental Rights Agency, we will include for first time specific cancer questions, the same as in the European Health Interview Surveys, into the LGBTI survey that the Fundamental Rights Agency will conduct. That's all. Thanks a lot. And I pass the floor to my colleagues in ESTAT. Thank you.
Thank you. So I will try to be very brief. So I will start by saying that there is a wide consensus in the European statistical system that we need improved statistics on equality at EU level, and we are stepping up the efforts in this direction. Points I want to speak. So the first is that Eurostat is already disseminating equality statistics. We have a dedicated page, and then there is information in the specific domains, including health. And there are substantial improvements in the short term, which are stemming from the 2019 framework regulation on social statistics. And for example, just to give quickly some example, we have a substantial extension of the scope for a background and disability in different various areas of life, like labor, education, living conditions, and we will have soon information on children disability, on disability employment gap, on the young people, not in education or in employment. We will have modules on discrimination in access to public services, including healthcare. We will have information on access to home care services provided by professional health or care workers. So there is a lot of information coming, and the second point is that we acknowledge that the coverage is low for several dimensions, and we have spoken today about the issues in measurement of concepts and the taxonomies in the ethnic and racial origin. So while acknowledging difficulties in this area related to the legal constraints, statistical disclosure, data quality, etc., we are starting the discussion with the national statistical institutes and relevant stakeholders to set the conditions for improving the collection of equality for having more comparable concepts, taxonomies, and safeguards for the data collection, given the sensitivity of the data. We acknowledge also that we need to have a participatory approach and involve relevant stakeholders and to identify complementarities, because not everything can be collected at EU level. So it's important to define the boundaries between EU, national, and local actors. So that's it. Thank you.
Thank you very much. Will we also still hear from your colleague?
No, I think it's fine.
Okay. Okay, thanks a lot for keeping it brief, and also thanks a lot for joining us, because it was relatively last minute that you joined, so therefore the agenda, and we're running out 1 minute, but I will make it 2 max. And I think it's a very important signal, and I think it's great to hear that you and your colleagues are so keen and having these conversations, in the background for these important steps to be made to tackle racism and discrimination, as well as other grounds of discrimination. Okay, thanks a lot for all the speakers. Thanks a lot the participants. I saw that Abigail has put in the chat the link to the third and last webinar that I mentioned at the very beginning. Just to repeat very quickly, we are working on this joint statement from DisQo that we will present at the Health Policy Platform annual meeting in April. If you're interested to contribute and or endorse it, please let me know as soon as possible, because we will be finalizing it shortly. And then what's left is to wish you all a very nice rest of the day. Thank you very much, and bye.
Thank you.
Thank you all.
Thank you and bye.